Hello, Dr. Soham, you can hear me? Dr. Soham, you're there?
Yes, ma'am, I'm there, ma'am.
Hello, am I audible?
Yes, ma'am.
Okay.
आहे ना हे झालं ना की लगेच टाकू नको ह्याच्यात ठेव लगेच
Dr. Archana?
Hello, ma'am. Good morning.
Hi, Dr. Archana, you can hear me?
Yes,
Yeah,
I can
hi.
hear you. Yeah,
How are you?
I'm good. How are you, ma'am?
Can't hear you. I can't hear you.
You can't hear me?
No,
Because Jyotirmay said that I'm audible.
no, I can't hear you. You can
uh,
hear
one-
me?
Yes, I can hear you. ऐकू येत नाहीये त्यांना.
Just see if you...
Sanjay, they are not able to hear me.
माईकचं वाढव पाहिजे मग काढून बोल माईकचं आहे
Soham, can you hear Dr. Archana?
Yes, ma'am.
I'm able to hear you. Soham.
Yes, ma'am.
Okay.
आता आहे ना
One person is able to hear me. Means it's audible.
हो सगळ्यात बेटर
मी ह्याच्यावर करायचं ना.
बोल्ट ऑडिओ
Now I can hear you. Yeah.
Oh, okay, ma'am. Okay, ma'am.
Yeah. Okay. Yeah, fine. Yeah, we'll get back on. Dr. Biswas, good morning.
Good morning. Good morning.
Good morning, sir.
Good morning. So we
Nice.
have, we'll have a case presentation from 11
Yes, yes.
to 11:45.
So I just
And I think Dr. Danda also may join us. So
Yeah.
around 11:45 or 11:50, once the case is over, your talk will be there. Huh? Yeah. Dr. Soham, are you there?
Yes, ma'am.
Yeah, we can see your slides, I think. So
Yes, ma'am. Ma'am, should I start, ma'am?
no, we'll wait.
Let the other.
It's still 5 minutes are left. No?
Yeah, I think
Okay,
we'll
ma'am.
start.
Yeah, other faculty will join.
Other faculty are joining.
Yeah.
Okay, ma'am.
So yeah. So we'll get back in 5 minutes. Huh?
Okay, ma'am.
Sure.
Okay. Okay. Dr. Manohar Joshi have joined. Dr.
Yes, ma'am.
Joshi, yeah. And Dr. Salil, yeah. I think Dr. Archana, Dr. Salil, Dr. Joshi, you can put your I think video on for a while. Dr. Soham, you're ready? Yeah. So very good morning to all of you. Welcome to the third Sunday morning session of Maharashtra Rheumatology Association Student Teacher Interface. So today we have faculty from Mumbai and Nagpur. We have Dr. Archana Sonawale, who is a professor of rheumatology and medicine at JCGS Medical College, Mumbai, also practicing with corporate hospitals in Mumbai, Wokat Hospital. Dr. Manohar Joshi is attached to D.Y. Patil Medical College and is a practicing rheumatologist in Mumbai. And we have Dr. Salil Ganu, who is attached to the Medical College in Nagpur and also practicing as a consulting rheumatologist in Nagpur. And the student today is Dr. Soham Chatterjee, who shall be presenting a case with a patient with skin tightness and breathlessness, etc. So we can start. Huh? We'll start.
Yes.
Yeah. Okay. Dr. Manohar, your mic is muted. And Dr.
Yeah, ma'am.
Salil, yeah. Okay. Over to all of you. Huh? Yeah. Dr. Soham, you can start.
Soham, you are muted.
Soham,
Yes, ma'am. Yes, ma'am. I just did.
yeah, you
Yeah.
can start. Huh? Yeah. Okay.
Sorry, ma'am.
Yeah.
Good morning, respected faculty and fellow colleagues. My name is Dr. Soham Chatterjee. I'm a fellow in rheumatology from Fortis Hospital, Mulund. I'll be presenting a case of a 44-year-old female who's a housewife by profession with chief complaints of intermittent episodes of bluish discoloration of the fingers since 8 years, tightening of skin since 8 years, heartburn since 6 years, breathlessness and weakness since 3 years, pain and swelling of the hands since 2 years, and ulcers on the toes and legs since 1 year. The HOPI includes the bluish discoloration of the fingers since 8 years, which has been gradually progressive, mainly in the fingers when on exposure to cold, and only while doing activities like washing her hands or washing utensils with cold water, or even exposing her hands to cold temperatures in an air-conditioned room. This feature was always intermittent and relieved only on warming or drying of the hands. The tightening of skin was also present since the last 8 years, which was slow in onset, and it gradually progressed, started off at the fingers and the hands, and then slowly progressed to her forearms. She also had symptoms of heartburn since the last 6 years. This heartburn was occurring more on lying down after a meal, or mostly at night time. This decreased on getting a sitting up or standing, and it was also associated with a feeling of her food coming up that she could feel coming up on towards her throat. She had complaints of breathlessness on exertion with an MMRC grade of 3. This was also slow in onset initially, and it gradually progressed. It was relieved on rest. It was associated with a dry cough whenever there was an exacerbation of the breathlessness, with no diurnal or positional variation of the breathlessness. She had an slow onset of weakness, which she said was more in her legs. She could feel that the weakness gradually progressed. She was unable to climb stairs, or she was having difficulty in climbing stairs and getting up from a seated position while sitting on the floor. She had symptoms of pain and swelling of the hands, which was also slow in onset and gradually progressive. It was unilateral at first, but started first involved the right hand in her palmar aspect, and slowly involved the fingers of the right and then the left hand, becoming bilateral over the years. Over the last 1 year, she developed ulcers on her feet. The ulcers first grew on her third and fourth toes on the right leg, and the fourth toe on the left foot. The ulcers were also present in the lateral aspect of the left leg distally, right above the ankle. This ulcer was bigger in size, and it also grew over the years, over the last 1 year. It had irregular margins with minimal discharge without any foul smell, that she said, associated with a continuous type of pain which was throbbing in nature. There was no history of erythema, fever, photosensitive rash, claudication pain, or inactivity stiffness. There was no history of orthopnea, pedal edema, PND, paroxysmal nocturnal dyspnea, and palpitations, oliguria, weight loss, hemoptysis, abdominal pain, or headache. She did not give any history of dysphagia at her first visit. There was no dryness of mouth, constipation, or diarrhea. There was no history of vomiting, muscular weakness, genital ulcers, and pain. There was no history of exposure to any chemicals either.
Muscular weakness was there actually. You
Yeah,
had
yes, ma'am.
mentioned that.
I think I
Yeah.
just wrote that. It's my bad, ma'am.
Okay.
There was no history of any other comorbidities in the past, including diabetes, hypertension, tuberculosis in her, bronchial asthma, thyroid abnormalities, or any cancers. Bowel and bladder complaints were absent for her. Family history was insignificant. In her medical history, she had chronic consumption of antacids since the last 2 to 3 years, which she gave a vague history of. The surgical history, she had to undergo a dental extraction of her right upper premolar, and a root canal was done in the past 1 year. The obstetric history, she is a P1A0 status. She has one son who's 7 years old. A menstrual history was regular and normal, lasting for 5 days with normal flow with no clots. She has no significant surgical history either. So moving on to the examination.
Before that,
Yes.
could you
Yes, ma'am.
summarize the history? I mean, you have given an excellent history.
Yes, ma'am.
I
Thank you,
think you
ma'am.
have covered most of the points, so there's
Yes,
nothing
ma'am.
more to add to. I think the only thing, maybe I'm not sure whether I missed it, but did you mention about her mucocutaneous manifestations, if she had any or didn't have, like hair loss,
Yes, ma'am.
photosensitivity, rash, oral ulcers, and all that?
Yes, ma'am.
Yeah.
Mouth
So,
ulcers and photosensitivity rash, ma'am. They were
yeah,
also not present, ma'am.
they
Ma'am,
were not
overall,
present.
no, ma'am. So, ma'am, overall, her symptoms were including the presence of uh, 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 the swelling of the fingers and the hands, breathlessness, but all the symptoms were preceded by Raynaud's phenomenon, for which had
Yes, for
lasted
at
for
least
about
8
5 to 8
years.
years.
Yeah,
8 years,
yeah,
yes, ma'am.
yeah.
Yes, ma'am.
So 8
Grad-
years history of Raynaud's, you are saying,
Yes,
followed
ma'am.
by slowly progressive skin thickening, gradually
Thickening, yes, ma'am.
progressive dyspnea. And you
Yes, ma'am.
said that recently she started also having symptoms of myositis,
Yes,
right?
ma'am. Yes, ma'am. Yes,
Yeah.
ma'am. Yes,
So,
ma'am. Muscle
uh,
weakness.
there was
Yes,
some
ma'am.
muscle weakness recently. You are not sure whether it is myositis. There
No,
was
ma'am.
no pain associated with the muscle weakness.
Not that she said, ma'am. No, ma'am.
So it was more of weakness, inability
Yes,
to
ma'am.
get up.
Yes.
Okay.
And climbing
So,
stairs. Yes,
and
ma'am.
climbing stairs, but there was no
Yes.
pain associated with that.
Upper limb
No, ma'am. No,
muscles,
ma'am.
upper limb muscles. Was there any clue of involvement of upper limb muscles, proximal muscles?
No, sir. So she did not give any history of inability to comb her hair or button her shirts or anything of that sort, sir. Most of it was only related to the lower limb, sir. She was saying it was difficulty walking at times and while climbing stairs or getting up from an up or up squatting. So
From the
nothing.
history,
Not involved.
No, sir.
okay. From the history, would you be able to make out whether the inability to walk was because of muscle weakness, or it was because of pain in the joints, or exactly what it was due to? Could you make out that?
Yes, ma'am. Ma'am, on climbing stairs, ma'am, she would say that her joints were not what was hurting, that she said. She would only say that when she was trying to climb the stairs, she would feel that she needed to rest and then climb the stairs again. So
But
rest
that
was
could,
helping her. Yes, ma'am.
rest would help her. Okay.
Yes,
Okay.
ma'am. Yeah, there was no pain on going up in the joints or in the thing. So, ma'am, that way I could probably differentiate.
And was there any buckling of the knees?
No buckling of the knee.
I mean, that would
Yes,
probably
ma'am.
help you in differentiating whether it was
Yes.
because of some arthritis or the contractures which were, you know, there will be no proper arthritis, but the contractures could be making her cause difficulty in climbing, if there are any. I mean, I'm
Yes,
not
ma'am.
sure whether they are, or there
Yes,
is
ma'am.
any claudication, or whether it is actual muscle weakness. So if there is
Claudication pain. Yes,
yeah,
ma'am.
yeah. Was there claudication?
Claudication pain was also not there, ma'am. I just mentioned it.
Yeah,
ma'am.
that was
Yes,
not
ma'am.
there. Okay.
Yes, ma'am.
Any
Yes,
sensory
ma'am.
symptoms?
No sensory symptoms that she also gave, ma'am. No
Uh,
sensory loss, no slipping of slippers.
uh,
Yes, ma'am. Yes, ma'am.
no tingling sensations or anything
No
like
tangling,
that.
no
No bladder
neuropathic
movement.
symptoms.
So
Yes, sir, bladder.
unlikely that it was anything neurological. So from your history,
Yes, ma'am.
could you summarize your differentials? Summarize and give your
Yes, ma'am.
differentials.
Yes, ma'am. Ma'am, patient with history of long-standing Raynaud's with a tightening of skin progressing with it, along with GI symptoms of reflux with onset of breathlessness. Ma'am, along with the swelling of the hands and the joints, hands and the development of ulcers, which points towards a vasculopathy as well. Ma'am, all of these together, along with a mild amount of myositis, probably points towards some kind of sclerosing condition because of the skin changes, but also should rule out vascular pathology causing the recurrence of the ulcers as well as the Raynaud's.
There is a non-healing ulcer in the lower limb, right?
Yeah, yes, ma'am, on the left
Yeah.
leg.
No, I mean,
as well.
with this kind of classical history, I mean, this is almost like a textbook
Almost.
picture of
Yes, ma'am.
systemic sclerosis. So I think you can commit on,
Commit.
yeah, even from your history, given all the features that you are mentioning over here, you can commit that she could be a patient of autoimmune rheumatic disease, probably systemic sclerosis, possibly pointing towards a diffuse cutaneous kind of systemic sclerosis.
You can do that.
Is a
Yes,
differential in that? Which other connective tissue diseases will you consider?
Yeah.
Ma'am, so in with these symptoms, apart from the heartburn, sir, and then the rest of the symptoms with the vasculitis predominance with recurrent ulcers as well as Raynaud's, so should rule out a vascular predominant, probably lupus, sir, or probably even a solitary vasculitis.
MCTD. I mean, when you're telling an exam that is a closest differential, you should always consider.
MCTD.
No,
Okay,
rather than lupus, I would say MCTD would be a more appropriate
Yes,
differential. Or
Yes,
she
ma'am.
could be, if you are saying that the muscle weakness has recently started, then whether she has developed into an overlap with myositis. Those two would be the second and the third differential rather than lupus. I mean, she doesn't really have all the features of lupus, right?
Yes.
Yeah. So
you have done quite a good job by ruling out
Thank you, sir.
all the clinical features that are there in other connective tissues. So good.
Yeah.
Good job.
Yes, sir. Thank you, sir. Yes, sir.
Yeah.
So
The
how
first-
long does it take from the Raynaud's phenomenon to go on to develop into a full-blown systemic sclerosis? What is the
Yes, ma'am.
average duration?
Ma'am, onset of Raynaud's phenomenon with severity even before the development of ulcers, within 2 to 3 years can develop a diffuse picture. However, in this case, it took a little longer, but as the years went on more of the symptoms came out even more frankly. But 2 to 3 years, ma'am, probably for the symptoms of diffuse.
On an average.
Allopathic complications may happen later, like you said. This ulcer started just 1 year back.
Yes, sir. Yes, sir.
Vasculitis has been there for a long time. So
Long time. Yes,
this
sir.
natural progression is mainly for the skin disease that they have described.
Yes, sir. Yes, sir. Yes, sir.
How do you differentiate a primary Raynaud's from a Raynaud's due to systemic sclerosis?
Yes, ma'am. Ma'am, primary Raynaud's, firstly, we need to rule out any kind of exposures of the patient, minus all medical history or medical examination or investigations. Any kind of environmental exposures to certain chemicals.
Clinically first, can you tell clinical features which are in favor of primary. Secondary? Yes.
Okay. Yes, sir. Primary will present with similar symptoms of discoloration of skin, whitening, paleness in the same way, but just that they will not be associated with other clinical features of skin tightening, contractures, or any kind of rash or ulcers associated with it. Along with this, there will be the secondary causes should be ruled out, of like exposures to chemicals like polyvinyl chloride or certain drugs like agotamines, SSRIs, agotamines and other kind of vasoconstrictors given for anything like methotrexate, clonidipine. After all of these is ruled out, ma'am, then we can consider primary cause of Raynaud's. After that, so a nail fold capillaroscopy could, as an investigation, could
that is
come
the
down to a
answer.
diagnosis of primary RP.
Yes, ma'am. Clues we were talking about, like anything related to unilateral nature, bilateral nature,
that's also
you need to mention. Yes.
Yes, sir. So even if there is
And
asymmetrical
also,
involvement of certain digits,
biphasic and
that
triphasic.
So for flow, sir.
The
Doppler flow,
Raynaud's description, no?
Yes, sir.
That also you should mention whether it is biphasic Raynaud's or triphasic Raynaud's. That gives some clue as to whether it is primary or secondary. Also, unilateral or bilateral.
Can you answer what is this biphasic and triphasic Raynaud's? What sir is mentioning?
No, sir. No, ma'am. So
I think it is self-explanatory, no? Biphasic and triphasic.
Is it related to the flow?
PR, PCR,
Doppler. Sir?
Pilar cyanosis icterus. Pilar cyanotis.
Okay. Whitening, pallor, and then bluish discoloration. So cyanosis.
So there are three stages, no? So,
yes, ma'am.
Yeah.
Okay.
Did you ask for history of any exposures in this patient?
Yes, ma'am. I asked for exposure of any chemicals, but she said that she's a housewife, so not going out as much, sir, ma'am. So nothing of that, sir. Ma'am, and to differentiate primary and secondary, also the nail fold capillaroscopy will show distinguished changes. The primary will show thin palisading capillaries right next to each other without lot of microhemorrhages, or maybe a few giant capillaries, but very less. And early systemic sclerosis will show giant capillaries with a few microhemorrhages. And active systemic sclerosis will show a lot more microhemorrhages with a few loss of capillaries and many giant capillary endings as well. And a late systemic sclerosis will show neovascularization with loss of capillaries with a lot of hemorrhages, microhemorrhages.
What is the characteristic feature of systemic sclerosis in nail fold capilloscopy?
A feature in nail fold capilloscopy, sir?
Characteristic features.
Characteristic features will be in a late systemic sclerosis, there will be loss of capillaries with multiple microhemorrhages and neovascularization as well. But an active will present with loss of capillaries, microhemorrhages, and lot of giant capillaries as well, sir.
Correct. Sure.
Yes.
Okay. So from history wise, I think we can go down to only these three differentials. The first one will be your diffuse cutaneous systemic sclerosis itself. The second would be with a probable association of myositis, whether it is an overlap or no, we will come to know from the examination. And there is also a component of a non-healing chronic ulcer. Which could you give a differential for that?
Yes, ma'am. A non-healing chronic ulcer could be.
Is she a diabetic? She's not a diabetic, right?
No.
There are no comorbidities. Okay,
no,
fine. Yeah.
So any kind of vascular pathology like probably atherosclerosis or any kind of emboli in this patient.
In this patient, what are the DDs of this ulcer, chronic ulcer, which is there?
So, ma'am,
I mean, what is the reason? What could it be due to the chronic ulcer?
Yes, ma'am. Ma'am, since the ulcers are present in the toes as well as on the distal aspect of above the ankle, the toes would have a differential of small to medium artery vasculopathy of any cause. Yes, ma'am. And the lesion on top of the ankle on the left leg would have a differential of probably a mid to large size artery vasculopathy, but most probably that kind of thing will have a recurrent, probably a clotting disorder which is causing a block there, causing recurrent ulcer. Even venous ulcer, it could be a venous ulcer as well with probably varicosities from before, as well as atherosclerosis or any kind of emboli in the distal larger arteries, ma'am.
Do you have a picture? Are you going to show us the picture later of this?
No, ma'am. I don't have.
You don't have any pictures?
Sorry, ma'am.
Okay.
You have an ulcer over this ankle.
Yes,
you
sir.
also have to consider a possibility of tropic component being there. These ulcers
Tropic.
time because of thickness, skin thickness,
Skin.
and
Mm.
recurrent friction develop there, and they are
Yes.
difficult to heal.
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
The classical cases of systemic sclerosis have ulcers and scars on the fingers.
Tips, fingertips,
Tips
right?
of the
Yes,
fingers.
yes, ma'am.
So, yeah, having an ulcer on the lateral malleolus, you are saying, no? It is over
On
the
top
lateral.
of the lateral malleolus. Yes, ma'am.
Correct. So, a lateral malleolar ulcer is classically seen in which condition? Usually,
Varicose
they are vasculitic ulcers, no?
vasculitis. Yes.
Yeah, vasculitic
Yes,
ulcers are seen on the lateral malleolus,
Vasculitis.
medial malleolus. So, could
Yes.
this patient be having a vasculitic ulcer, not a vasculopathy ulcer? I mean, what is the difference, and how will you come to know which one
Yes,
of the two it is?
Ma'am,
Can patients of systemic sclerosis have ANCA positivity, or can they have vasculitis?
the ANCA positivity in systemic sclerosis, ma'am, I'm not aware of. But vasculitis overlapping with this can present as an overlap with a lot of dry mouth, Zika symptoms, and with features of lupus as well. So, as an overlap syndrome, probably it could present as a vasculitis.
So, if it is an overlap, yeah, then
Yes.
it can present as a vasculitic
Yes, ma'am.
ulcer, right?
Yes.
Because
Yes, ma'am.
most of the times, what ma'am is saying, the ulcers in scleroderma are very small, tiny, digital
Yes,
fitting
ma'am.
scars which you see, not
Yes,
the
ma'am.
large ulcers on the malleoli.
Malleolus, yes.
So
Mm.
that makes you think whether there is something else going on.
Going on. Yes, ma'am.
Right?
Yes.
So what are the
Another
commonest
thing
site
you
where
should
you can
remember-
get these abrasion ulcers
Yes, sir.
Sorry,
in systemic sclerosis?
could you repeat
Yes,
the
sir.
question, sir?
What are the commonest site where you can get these abrasion ulcers more commonly?
Yes, sir.
Abrasion ulcers. Yeah.
Yes, sir. Any sir, ulcers of this category where can happen in the areas of common trauma, sir. Where also in areas where the skin is thinned out due to probably chronic avascularity. These are areas like the dorsal aspect of the MCPs, the dorsal aspect of the PIPs, and sir, also the towards the tip of the toes, sir, of bilateral toes as well.
So you are saying that this female is more commonly a housewife. So where will you expect that such a long-standing history of systemic
Yes,
sclerosis, the patient will develop the abrasion ulcers? Will it be
mostly.
foot or somewhere else?
Sorry, sir. Will it be
Foot or somewhere else?
mostly in the hands, sir? Is what I would be expecting.
Exactly.
Because of
Yeah. So it will be around your wrist.
wrists. Yes. Yes.
More over here.
Yes, sir. Yes, sir.
So that's why
Yeah.
we are pitching towards the history, whether it's a vasculitis, what is the
Vasculitis.
patient developing at the lateral malleolus.
Yes, sir. Yes, sir. Yes.
So
sir.
what is
That
the difference between vasculopathy and vasculitis?
So vasculitis will be involvement of the layers of the vessel wall, like the intima or the media, causing chronic hypoxia or ischemic damage. Vasculopathy would involve more of involvement of a luminal block due to multiple reasons like a procoagulant state or hyperviscosity, something causing ischemia overall in the long stage. So, sir, in this patient, the lateral proximal aspect of the lateral malleolus is presenting as an ulcer, points more towards probably a vasculitis picture. So, probably this patient has an overlap.
See, I beg to differ. Thing is,
Yes, sir.
when you have a classic picture like this, which is exclusively scleroderma,
Yes,
right?
sir.
Although it is not impossible, but
Yes, sir.
vasculopathy is the thing that we see.
Yes.
Vasculitis per se is not very common.
Not very common.
Yes, sir. Yes, sir. Yes, ma'am.
Only the site makes you think whether there is anything.
There is
else.
any. Yes, ma'am. Yes, ma'am. Yes, ma'am.
Yeah.
Yes, ma'am. That is.
Okay. Anything else in the history? I think we can go on to the examination now.
Yes, yes.
I go on to examination, ma'am. Yes, ma'am.
Ma'am, only one question. So what are the diseases that can mimic otherwise as a systemic sclerosis?
Yes, sir. Yes. So conditions which can mimic systemic sclerosis if it is not spread out entirely to the in a diffuse pattern over the skin, then a localized scleroderma can present as the same way. If not scleroderma, then the other conditions like sclerodema, scleromyxedema, eosinophilic fasciitis, NSF, nephrogenic sclerosing fibrosis. A graft rejection sometimes can present as a sclerotic lesion. Paraproteinemias can present as sclerosis, like syndromes like Poem syndrome. So other conditions.
What is morphia?
Morphia is a type of localized scleroderma, ma'am. This can present in two types. It can present either as a plaque morphia or a guttate morphia. Plaque morphia would be lesions of thickening of skins in 1 to 2 sites of the body, which are more than 1 centimeter in size. And guttate morphia would be presence of smaller lesions, but in multiple areas of the same type as plaque morphia itself. These are kinds of localized morphia. So then there are drug exposures which can lead to, or exposure to chemicals which can lead to scleroderma mimics, like bleomycin, hydroxyurea, chemo or radiotherapy, ergotamines again, and yes, sir. So conditions like these.
Okay.
So how will you clinically differentiate between these when you have a patient of, say, scleroderma, sclerotic myxedema, and systemic sclerosis? What are the clues that tell you that this is probably a connective tissue disease rather than?
Yes, sir. Scleroderma essentially involves about an overall of two types. Scleroderma can be associated with diabetics, which is called scleroderma diabeticorum. In which case, a preceding history of diabetes has to be elicited, which can rule out this. Scleroderma also tends to occur in people with after an infection. So a viral infection in the past, which followed by sclerotic features of the skin, could point towards scleroderma of Buschke. So apart from this, scleroderma is also associated with thickening, which spares the palms and the feet, whereas this will involve more towards the proximal areas.
And
so, yes, sir.
And something related to vessels, Raynaud's.
Raynaud's will not be there. Yes, sir. Yes, sir. Yes, sir. Yes, sir. So those things we can differentiate, sir. Yes, sir. So other conditions, so NSF can be differentiated with the previous history of oliguria, anuria, or any kind of chronic hypertension, diabetes.
Fine.
So
Fine.
Yes, sir.
I think we can go on to examine.
Go on to the examination.
Yeah. Yes, ma'am. Yes, ma'am. In general examination, ma'am, patient was conscious, cooperative, oriented to time, space, and person. There was no pallor, icterus, clubbing, cyanosis, or lymphadenopathy. There was edema present in the hands bilaterally.
Up to
the wrist.
Only up to the wrist.
Wrist. Yes, ma'am. So fingers and the dorsal aspect of the
only
palm.
hands, not in the forearm and the arms.
And not in the forearm, ma'am. Only till
okay.
Yes, the blood pressure was 110/70 millimeters of mercury, a pulse rate of 86 beats per minute, saturation of fluctuating between 96 to 97% on room air, with a respiratory rate of 18 to 20 per minute. She was afebrile on examination. On general examination, there was skin tightening present over the dorsal aspect of both the hands, bilateral forehands, the face, as well as the chest area. She had as well as the feet. She had an overall MRSS of 10. On oral examination, ma'am, they had she had microstomia. The oral cavity seemed dry. There was an extraction done on the second molar on the right, superiorly. The ulcers present on the lower limbs, were present on the third and fourth toes on the right leg, foot, and the fourth toe on the left foot. These ulcers were about 2 to 3 centimeters in size, all of them having irregular borders with a white pustular discharge at the base. 2 of them on the right foot had a small bleeding points as well. There were erythematous margins, and it was also tender on palpation. Ulcer on the left leg, on the distal aspect, right proximal to the lateral malleolus, was showing pustular discharge along with irregular margins. erythematous, irregular and erythematous margins, and it was also tender on palpation.
So two things. One is that,
Yes.
could you go back to the previous slide?
Yes, yes, ma'am.
One is that if we had pictures, that would be really helpful. So
Yes,
next time, I
ma'am.
think we
Yes.
can do that.
I'll do that, ma'am.
Now,
Sorry.
if you are saying skin tightening and edema both occurring together is a little
Yes,
unusual. I mean, if you are having edema, then
Yes, ma'am.
there will not be much edema with skin tightening doesn't go so well. So I mean, we are not really
Okay.
able to imagine that. If you had a
Okay.
picture, maybe we could be able to make out.
Sure.
But
Yes,
I mean, if you are having edema, that means it is still in the early stage. A
Mm.
patient who's had Raynaud's phenomenon 8 years ago and the disease has started almost 8 years ago will not be in the edematous stage at present. So whether there is
Yes.
any other reason for edema, that we have to think of.
Okay,
And
ma'am.
that occurring with skin tightening usually doesn't go, I mean,
Occur.
yeah. So
Yes, ma'am. Yes, ma'am.
Dr.
Yes, ma'am.
Dr. Ganu, you want to say comment on this?
I agree with this.
Yes, ma'am.
I mean, if you have edema, you can't be having too much skin tightening.
Difficult.
Tightening.
Yeah,
Difficult.
difficult to
Yes.
It is difficult to check on examination.
check on examination also. Yeah.
Yes, ma'am. Yes, ma'am.
Okay.
Ma'am, on presentation, ma'am, actually she had presented around 2 years back. Right now that I saw her edema was much lesser, but the
Yeah.
first time when she had come, her edema was much more apparently.
That's fine. You can
Yes, ma'am.
you can present
Probably.
the present when you are examining
Present.
her, presenting her now. You have to tell the present examination.
Yes,
Right?
ma'am. Yes, ma'am. Yes, ma'am. Yes, ma'am. Yes, ma'am. Okay, ma'am. Ma'am, on systemic examination, CVS, ma'am, precordium was normal, S1, S2 was heard, a loud P2 was heard, best at the pulmonary area, best heard on inspiration. It was not associated with any murmurs. The respiratory system showed was normal on inspection. Chest movements were normal as well. No scars or sinuses or deformities. There was a reduced vocal fremitus on auscultation as well. Normal vesicular breath sounds were heard. Otherwise, fine
No,
crepitation.
see, vocal fremitus is tactile.
Sorry, palpation.
And vocal resonance is auscultation.
Yes,
And
ma'am.
also, you have to mention in which area of the chest, because
Yes,
it
ma'am.
won't be reduced in the entire this thing. No?
No, ma'am.
So according to the areas, na, inframammary,
Yes, ma'am.
mammaries, all that.
Yes,
So
ma'am.
you have to mention that. Okay.
Yes, ma'am. Ma'am, the vocal fremitus and the vocal resonance on palpation and auscultation respectively were reduced in the middle and lower zones. In that is specifically on the intermammary and inframammary areas.
And don't mention zones in zones are in X-ray, and areas are on examination. So
Okay, ma'am.
inframammary.
Okay. Yes, ma'am. Intermammary and inframammary areas were where the vocal fremitus was reduced, along with reduced vocal resonance on auscultation. Fine crepitations were also heard in the similar areas of inframammary and intermammary areas as well.
Posteriorly, there was nothing.
Posteriorly only, ma'am.
So that will be infrascapular.
Scapular, intrascapular.
Posteriorly, it is interscapular, infrascapular.
My bad,
Laterally,
ma'am.
it is axillary and infraaxillary.
Yes, ma'am.
And
Yes,
no,
ma'am.
that's okay. Don't feel bad. So those are the areas, because crepitations you expect to hear more prominently in the back, no?
Posteriorly, yes, ma'am. That's where it was, ma'am. It was in the back only. Yes, ma'am. Interscapular and infrascapular area. Yes, ma'am. My bad. Yes, ma'am. Per abdominal, ma'am, there was no organomegaly, no tenderness, dilated veins, scars, or sinuses. On CNS examination, he was conscious oriented. There was no cranial nerve deficit. Higher mental functions were normal. There was no sensory deficit or cerebellar signs as well. On motor examination, there was bilateral lower limb proximal muscle weakness, in which the flexion and extension were showing of the knees was showing a power of 4 bilaterally. There was no motor deficit in the upper limb though.
What about the hip? Flexion extension at the hip?
Hip flexion extension, ma'am, I didn't find any weakness as of now, ma'am. But
only at the knee.
Knee on flexion extension, I could feel that she couldn't do it that properly, ma'am. The tone and the mid thigh circumference seem to be a little lesser, and she said that I have also lost some amount of mass there as well. The reflexes were intact. The knee jerk and the ankle jerk were intact though. There was no clonus and there was no fasciculation present.
Did you
On
see any obvious wasting?
Ma'am, it was not so frank, ma'am, but the circumference was reduced on noticing, sir, ma'am. It looked, I mean, it was not very prominent, ma'am. So that's why I didn't mention the wasting part. But reduced, there was thigh circumference which was reduced, ma'am.
And
So
the tone was actually normal. So do you
was
think
also
this is
normal.
neurological, or you think it is just?
Yes,
I
ma'am.
mean,
Ma'am, either a UMN or an LMN lesion could also cause weakness in that area if it is segmental. But the absence of clonus rules out an UMN, and even fasciculation rules out an LMN lesion. Reflexes being intact, if it is the case of myositis, it would probably be reduced. But in this case, the reflexes were also intact. So, ma'am, in that case, it did not feel like a neurological cause of weakness.
It seems
yes,
to be just muscle wasting,
which
which
localized,
is,
yes, ma'am.
local
Post-synaptic.
wasting.
Yes, ma'am.
Okay.
Yes, ma'am. Yes, ma'am. On musculoskeletal examination, there were changes of sclerodactyly in bilateral hands. It presented, there was a dorsal aspect of the hands were edematous, with more edema on certain fingers compared to the others, but all were edematous overall. The second, third, and fourth phalanx of the right hand and the second and third phalanx of the left were more edematous than the other fingers. There was shortening of the distal phalanx of the second right digit. Contractures were present in all the fingers, with restriction of movement present at the MCP and the PIP bilaterally. A finger to palm distance was measured to be around 1.8 to 2 centimeters only. She couldn't flex it entirely. Tendon friction rubs were present on palpation of the palmar aspect of the second and third and fourth MCPs, which were very, very prominent. After eliciting it twice, could not feel it again, but after waiting for a while, it would occur again. This same thing would occur on the second and third MCP of the left hand as well. In the lower limbs, the bilateral, the thigh muscles were tender, mostly in the quadriceps area on palpation. There was a reduced muscle bulk, but like I said, ma'am, it was not really frank though. There was weakness on flexion of and extension of the knee. Bilateral knees seemed inflamed, ma'am, with crepitus present bilaterally. So, and there were contractures present on the toes as well. There was shortening of the fourth and fifth toe on the right foot as well. Yes, ma'am. So these were the findings on MSK, ma'am.
So there was muscle tenderness.
There was tenderness, yes, ma'am. On palpating, there was muscle tenderness as well.
That's a significant finding which could change your.
Yes, ma'am. Yes, ma'am.
Okay.
Yes, ma'am. Yes, ma'am. On investigating
in the upper limb, there was no tenderness. In the arm,
upper limb, there was no tenderness. There was no weakness as well. Power was 5/5.
What about neck flexors?
There was no weakness in any other areas, ma'am.
No truncal weakness. She was able to turn in bed and get up on her own, and there was no neck flexor.
Yes, ma'am, but she could not get up after sitting on a lower level on the closer to the ground. She could not get up without support.
From the bed, she could sit up.
From the bed, if she lying down, she could sit up. Yes, ma'am.
She could sit up. There was no neck flexor weakness.
There was no truncal or neck flexion weakness, ma'am.
Dr. Ganu was asking something.
Around hip, so it was normal, right? I mean, gluteus.
Yes, ma'am. Yes, sir. So hip flexion as well as extension was not seeming to be a problem. I could not. Yes, sir. I could not find a weakness in that as well.
5/5. It was 5/5.
5/5. Yes, sir. Yes, sir.
Okay.
So on investigation, back 2 years back when she was investigated.
After your examination, what is your conclusion? I mean,
yes, ma'am. Yes, sir.
Is a phenotypic disease? What is the extent? What is the severity? And what do you expect if you consider antibodies? What will you anticipate in this case?
Anticipate, yes, sir. Yes, sir. Sir, involvement of the CNS, including a weakness of the proximal muscles, was the only finding. Apart from that, the CVS showing a loud P2, which shows a pulmonary involvement. No abnormality.
Can
The
you tell your
muscular.
conclusion that this was a systemic sclerosis with this involved like that?
Just summarize your history and examination finding and tell us a
Just give
conclusion.
your diagnosis because
And give your diagnosis.
Yes.
You have to wind
Yes,
Before
sir.
going to the investigation.
Investigation. So involvement of the GI tract along with the sclerodactyly features, along with the Raynaud's history of about 8 years, points mostly towards a diffuse, probably phenotype of systemic sclerosis in this patient for me, sir.
So why is there muscle tenderness?
You said that this is did not extend beyond wrists, I suppose.
The edema, yes, sir.
Skin tightness.
Till
MRS
the forearm,
only 10. Did she have
Only
a
10,
history of this in the past? Because in history it was not mentioned as in which all areas were thickened.
yes, sir.
Now it looks
Yes,
like a limited cutaneous systemic sclerosis from the description on examination.
Yes, sir.
That
Yes,
can
sir.
happen. Patients may have improvement in skin tightness later on in the course of disease. So was
Yes,
it
sir.
present in the past that?
Yes, sir. So 2015, 2016, when she had started with the onset of the disease, since then only she has been mentioning about her skin tightening only in her hands, forearms, and little bit on her feet. But on examination, there was also
So
facial tightness
up
and
to what extent is it called limited cutaneous and beyond what is it called diffuse cutaneous?
yes, ma'am.
What level is it that you call?
Limited cutaneous would be involving only the fingers and the hands and
Up to the
and the face as well as up to the wrist, up to the feet, up to the ankle. Limit up to the forearm and the knee with the face would.
There is a classification which you are describing to that is called
Yes.
type 1 limited cutaneous.
Yes, sir.
But
Yes,
generally accepted thing in limited cutaneous and diffuse cutaneous is elbows and knees. If it is
Yes, sir.
proximal to, like, if the area proximal to elbow
And knees is, then it's
not,
diffuse.
I think
Yes.
there is some disturbance, Dr. Ganu.
So I was telling that what you are telling is
Type 1, type 2 limited, sir.
that those are different things. What we are asking
Okay.
is whether it is limited
sir.
or diffuse. That
Okay,
differentiate is done based on levels at elbow and knees.
And knees, sir. Yes, sir. Yes, sir. Yes, sir. More than the forearms and elbows, if it's proximal to that, the elbows and the knees, then it's going to be diffuse, sir. Yes, sir. And so type 1, type 2 would be up to the wrists and the ankles would be type 1 limited, and type 2 limited would be up to the knees and to the elbows with the face.
So this was a limited cutaneous systemic sclerosis with internal organ involvement, with ILD, with GI involvement.
Yes, sir.
Vasculopathy.
Yes, sir.
How
Pulmonary hypertension.
and
Pulmonary hypertension. And so skin thickening was also on the chest, sir.
So that's what I was asking.
So that's
Yes,
what
sir.
sir is asking, whether it is diffuse or
Yes,
limited.
It
So,
was-
okay,
it
so
was on
skin
the chest
thickening was
as well,
present everywhere.
No,
Okay,
chest
okay.
only. Yes, 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 sir.
I
Yes, ma'am.
don't think you mentioned it in your examination, did you?
No, sure.
Chest?
In thickness, I didn't.
No.
Yeah.
Oh.
So if it is present
Oh,
on the
okay,
chest,
okay,
then
okay.
it becomes a diffuse cutaneous. No?
The chest was
Yeah.
also there. Yes, ma'am. Yes, ma'am.
Also,
It's
prognosis
11:43.
prognosis and
Excuse
natural
me.
code depends on that. I'm sorry.
It's
sir.
11:43. We'll
Yeah,
have
yeah,
to
sure,
wind
sure.
up
Yeah.
in 7 minutes.
Let's wind up. Yeah. So your this thing is diffuse cutaneous systemic sclerosis with pulmonary involvement, pulmonary arterial hypertension, ILD, and GERD, right?
GID. Yeah, yes, sir. Yes, ma'am.
And
Yes.
a vasculopathic ulcer over
Ulcers.
the left malleolus, lateral malleolus,
Malleolus and toes. Yes, yes, ma'am.
and over the toes. Okay.
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Fine. So how will you investigate? What investigations have you done?
Ma'am, so to quantify the pulmonary involvement, to differentiate between a lung pathology and the arterial pathology, pulmonary artery hypertension, an HRCT and a pulmonary function test was done on her. The HRCT was showing.
Can we go to the investigations?
Yes,
You had the next slide. No?
Yes, ma'am. Ma'am, this was the overall, ma'am, this was the ANA was sent for the patient, which was showing a 1:1280 with a nucleolar pattern, along with a blot showing an SCL70 and a Rho 52 positive. On the first time when she visited us, these were the blood reports for her, which was showing an hemoglobin WBC platelet of 10, 8.31, and 3 lakh. SGOT PT. Yes, ma'am.
Tell me the three specific antibodies that you do, which we don't routinely do, but which
Yes,
are specifically there for systemic sclerosis.
Associated, ma'am. Ma'am,
Huh.
three main
Antibodies.
antibody subsets on reflex testing would be mostly SCL70,
Which is also called
topoisomerase,
right.
and anti-centromere antibody and RNA
Correct.
polymerase 3, ma'am.
Correct.
Of these, yes, ma'am. Yes, ma'am. Of these, the SCL70 mostly, the anti-centromere mostly points towards the limited cutaneous involvement with lot of pulmonary involvement, as well as the digital ischemic symptoms will be very high. The SCL70 will have a lot of organ involvement, but diffuse organ involvement, but with preceding Raynaud's phenomenon, as well as heart and joint involvement, joint with contractures and tendon friction rubs will be very, very profuse. Anti-RNA polymerase 3 would be associated with skin and tendon involvement, which is also diffuse and very progressive. It would go on to involve the muscular tendons and joints, so it could present with fibrosing myopathy or friction rubs and
significance of tendon friction rubs in prognosticating.
Yes, ma'am. But tendon friction rubs mostly points towards an organ involvement, which will be it is a red flag sign to give you an idea about organ involvement in the coming future, ma'am. Mostly ILD and cardiac involvement is expected. Also, ma'am, with RNA polymerase 3 has a higher chance of developing renal crisis
Cancer.
and ma'am, vascular ectasia, ma'am.
And also cancer.
RNA polymerase also be cancer, yes, ma'am. Breast and lung cancer.
Right.
Will you treat this patient?
In this patient, depending on the HRCT and the DLCO findings, the DLCO was very low, less than 55%, and showed a 20% reduction. So a right heart catheterization should be done to probably find out about to quantify the pulmonary artery hypertension. After which, if the HRCT showing minimal changes, less than 20 to 30%, along with pulmonary artery hypertension, then we should treat the pulmonary artery hypertension first with either endothelin receptor antagonists, phosphodiesterase inhibitors, or
can you give a combination of both?
Yes, ma'am. Yes, ma'am. Combination of endothelin receptor antagonists and PDE5 inhibitors should be considered when it is pulmonary artery hypertension and dyspnea is not responding, and also keeping in mind the side effects of hypotension, dizziness, etc. in the patient. CCB should be avoided.
Okay, yeah, go on, please.
Yes, ma'am. CCBs should be avoided if the patient has a cardiac involvement in the form of diastolic dysfunction, or if he has GARD, like in this patient who has prominent symptoms of GARD and heartburn, because some CCBs like nifedipine could cause smooth muscle dilatation and worsen the reflux, and the diastolic dysfunction could also get worse. Hence, they should be avoided in pulmonary artery hypertension with overlap of GI symptoms and cardiac symptoms. Ma'am, apart from that, if the symptoms still persist, administration of prostacyclins could be considered. In this patient, because of the rapid progressive skin changes which are occurring, along with the PAH, IV prostacyclin cycles or regular cycles of prostacyclins could be considered. Selexipag, trepoprostenil, iloprost, or could be considered in this patient as well. Apart from this, the skin changes needs to be worked upon also with the same principles in mind.
Intractable pitting digital ulcers?
Yes, ma'am. Ma'am, if digital ulcers
not getting treated with
yes, ma'am. Intractable ulcers, and to prevent the formation of new ulcers, trials have shown the efficacy of bosentan, ambrisentan. Majorly, bosentan prevents the formation of newer ulcers as well. If it is still not getting this thing, then a combination with PDE5 and endothelin, along with regular cycles of prostacyclin, ma'am. alloprostidil probably could be used in this patient. And if that also does not correct it, then we should consider either arterial surgical procedures like arteriolysis or stenting, or sympathectomy, which is localized.
I think we'll have to just give a short feedback and stop, because we have got a guest speaker waiting. So yeah, Dr. Joshi, you can just 1 minute each, you can just give a feedback to him. Yeah.
Ma'am, only he has not mentioned about that diffuse whether limited was only the thing which was missing. Rest all he has picked up everything. Only the thing whether he has said that there was some loss of muscle bulk over the thigh region, whether it was that or it was again the tightening of the skin which was limiting or making you believe that there was a loss. So
Yes.
it can be again the diffuse thing which you are looking at.
Yes, sir. Yes, sir.
Only the thing that was missed. Otherwise, he has covered the rest investigation, and yeah, the treatment part has to be discussed in detail.
Yeah, I think we're a little short of time. Dr. Archana,
Out
your
of the
feedback?
time we are missing it.
Yeah. Dr. Archana?
Yes. Yes, sir.
Yeah. Dr. Archana, any feedback for him?
I think there is some problem with my internet. Can you all hear me?
Yeah.
Yes,
The
ma'am.
voice is breaking,
Can
but
you
we
hear
can
me?
hear you. Yeah.
Yeah. So
Yeah, we can't hear you. Yeah. Dr. Ganu, just you can
Yeah.
sum up. Yeah.
It was a good case, very, very well presented. You have covered almost everything. I would just say that you be precise when they ask you a particular thing. That particular thing, if you can tell, that
Yes,
will
sir.
help you in examination. This is from examination point of view, I am telling. Otherwise,
Yes.
good case, good presentation.
Yes, sir.
Thank you so much. Thank you so much, Dr. Archana, Dr. Joshi, Dr. Salil Ganu, Dr. Soham, you did a very good presentation. Just stop sharing your slides, please.
Yes, yes, ma'am. Thank you, ma'am.
So I take great pleasure in welcoming Dr. Jyotirmay Biswas. He's the Director Uveitis and Ocular Pathology at Shankar Netralaya, Chennai. Dr. Danda, sir, are you there?
Yes, I'm there. Thank you.
Yeah.
देवाशीष दांडा डॉक्टर दांडा साहेब
Hi, hi.
मला खूप भालो लागलो আপনি
Thank you.
আমার খুব
So I
ভালো
thought since
Thank you.
Dr. Danda introduced us, so I'll invite
Yes.
him to welcome Dr. Danda. As you all know, is the professor, founder of the Department of Immunology and Rheumatology at CMC Vellore. Over to you, sir, to introduce our guest speaker, and we'll
Thank
go
you.
on to the next guest.
Thank you. Thank you for this opportunity again to be with you all. And it's really my pleasure to introduce Professor Biswas, a real stalwart in the field of uveitis, not only in this country, but overseas also. Dr. Biswas and me had interacted many times, and I'm very fortunate to be a good friend of him in the recent years. Dr. Biswas had specialized in uveitis and ophthalmic pathology. He has done his fellowship in vitreoretinal surgery from Shankara Netralaya, Chennai. And he also did his fellowship in ophthalmic pathology from Doheny Eye Institute, University of Southern California, USA. He had published remarkable 522 articles in peer-reviewed PubMed Index journals and 65 chapters in textbooks of ophthalmology. He presented over 300 papers in national and international conferences. He had given 400 lectures at least. He had 4 books on uveitis and 1 book on ophthalmic pathology. He's a reviewer of 52 journals. He is a visiting professor at Advanced Eye Care Center at PGI MER Chandigarh and the Chinese University of Hong Kong. He was the principal investigator of 13 research projects. He has mentored 48 uveitis fellows. He has received 51 awards, including Hariom Ashram Award from Indian Council of Medical Research by the President of India. He is a member of the International Uveitis Study Group, American Uveitis Society, and Executive Council member of International Ocular Inflammation Society. He is the founding member and past president of Uveitis Society of India. He was the first to describe ocular lesions in AIDS in India. His current research interests include uveitis, AIDS, and Eales disease. Currently, he is working as director of Uveitis and Ophthalmic Pathology Department at Shankaran Nethralaya, Chennai. I'll also add one more sentence by saying that Professor Biswas is so much respected abroad. I'm sure all of you know about Professor Rosenbaum. Professor Rosenbaum is an ophthalmologist who later became a rheumatologist. So he actually is specialist in two areas. I had met him once in one of the ACRs, I think in Boston, about a decade ago, and I was talking to him about discussing difficult cases. And he said, you have Dr. Jyotirmay Biswas in India, you don't need anybody else. You don't have to contact me. So this is his reputation. So I'm really honored to introduce my friend and my Dada, Dr. Jyotirmay Biswas. Welcome, Dada.
Thank you.
Thank you so much, Dr. Danda. So over to you, Dr. Biswas. You can share your slides. The topic today is eye in autoimmune diseases, because this was a topic by popular demand from all our students. Over to you, sir. Thank you so much for accepting the invitation. Thank you, Dr. Danda, for introducing him. Yes, sir.
Is my slides visible?
Yes, sir. You can go to the slideshow. I think slide is
Yeah.
visible. Yes, sir. Yes, sir.
At the outset, I am so overwhelmed with the kind introduction to me. And it's a really an honor and privilege. And I'd like to thank Dr. Kavita Krishna, Professor and Head of the Department of Clinical Immunology and Rheumatology, Bharati Vidyapith University Medical College and Hospital, Pune. I learn uveitis every day from rheumatologists. And it's the interaction almost every day. I call my rheumatology friends and colleagues and treat with uveitis or scleritis cases. Without their help, I won't be able to, I'm not able to manage the patient. And today I am privileged to talk on a disease called eye in autoimmune disease. I'll be taking about 30 to 40 minutes time. At the outset, I like to tell you that eye is a wonderful organ, and it's a transparent organ. You can see the structures of the eye by looking into the naked eye or instruments. And it's also a very small organ, 2.5 centimeter in size, and it has got 3 layers. And here is got beautiful structures like retina, which has got 10 layers. Cornea has got 4 layers. And lens, which is the clear subject, clear matter organ. And then there's a fluid in the eye, anterior chamber, and aqueous, and back in the vitreous. And it's also one of the organs which is immune privileged. And we don't have lymphatics in the eye as such. In the orbit might be having. And we get a lot of autoimmune diseases in the eye, and we can see it. And another important thing is that you can see it. It's a window. Eye is the window of the body. Many of the systemic diseases can be manifested and can be evaluated, prognosticated, and treated. So I'll be talking today about the uveitis and scleritis mainly, and then the autoimmune aspect of it, how it is, what are the autoimmune diseases in the eye. Coming to the uvea, there's a part which will be concentrating. It has got the middle coat of the eye shown in the pink color over here. It has got iris, anterior part, middle part ciliary body, and in the choroid, the posterior part of the eye. And then there are 4 anatomic types of uveitis: anterior uveitis, iris and ciliary body, intermediate uveitis, anterior vitreous, and the pars plana region, and the posterior portion in the retina and choroid. Pan-uveitis when it involves all the organs of the body. With this backdrop, I like to talk about infectious and non-infectious uveitis. I'll be concentrating of the non-infectious uveitis, which comprises about 50% of the uveitis cases. Non-infectious uveitis can be autoimmune or idiopathic. There is not a good compartmentalization between the two. And autoimmune uveitis is one of the bugbear in ophthalmology. And I'll be talking about sympathetic ophthalmia, a peculiar disease which involves injury to one eye, involves the other eye. It's a paired organ, eye is a paired organ, which you don't see any other organ in the body. It's a very specific phenomena. Then I'll be talking about what chronic heart disease. I'll be spending a little time on systemic lupus erythematosus, which is a challenge to the ophthalmologist and should be the challenge for the rheumatologist also. Baser's disease, juvenile idiopathic arthritis associated uveitis, HLA-B27 syndromes, ankylosing spondylitis, Bloss syndrome, Tinu syndrome. And we'll be talking a little bit about the scleritis also. Let me start with sympathetic ophthalmia, which is a classic autoimmune disease. And what happens here, I just go back to a 25 years back when there's a Mahabharata serial was going on, and the children seeing the serial was playing with the bow and arrow, indigenous bow and arrow, and a 12-year-old boy from Patna had a bow and arrow injury in the left eye. His left eye, as is shown over there, is a thicicle, becomes shrunken in size and lost the vision. But the things becomes a real problem when the right eye, after 1 month, which is not injured, had lost vision completely, almost completely after 1 month. And this is the picture of the right eye, have done white deposits on the back part of the cornea, and the optic nerve is swollen, and there is a serous retinal detachment. And this patient, what I did, I found that this is a phenomena which has not been diagnosed over there. It's a sympathetic ophthalmia. It's an autoimmune disease. So I straight away put the patient on azathioprine and steroid. And over the 2 months period of time, the child fortunately got back vision 6/6 in the sympathizing right eye. And this is the right side, left side is the previous picture, and the right side you can see the complete resolution of inflammation, and the retina is attached. That is not the end of the story. This patient, after 25 years, connected with me with Facebook and wrote to him that he is grateful and he is doing postdoctoral fellowship in Finland. And that was that made my day, and it was a really great joy that we could make a difference by diagnosing properly and adequately treating it. And this was my first patient of sympathetic ophthalmia, which I treated with immunosuppressive agent. What is sympathetic ophthalmia? It's a rare bilateral granulomatous panuveitis. As I mentioned, is a classic autoimmune disease. We have got exciting eye, which can occur following surgical or accidental trauma, like penetrating trauma, as it happened to this child, and the sympathizing eye. This is an uninjured eye, which developed uveitis after apparently normal eye after a latent period of 5 to even 62 years after developing a sympathetic inflammation. And then trauma surgery, how it happens? They release the antigens such as proteins from the uveal tract, uveal pigment or the retina, and subsequently induce autoimmune uveitis. And we see this a classic example of autoimmune uveitis. We get CD4 T lymphocytes in the early phase and CD8 T lymphocytes in the chronic stage. It doesn't happen to everybody. There's got HLA association, HLA-DR B104, HLA-DQ B104 has been found to be associated with it. How common it is a very rare 0.044%. And then following, now it has happened, a new entity has come, is a surgery. Following vitrectomy, which you do that posterior part of the one, which is a very common surgery, and where you make an opening in the through the pars plana region, ciliary body region, and this opening acts as a penetrating trauma, release uveal antigens, and produce sympathetic ophthalmia. And this is a picture of a sympathetic ophthalmia. You can see that normal nerve is swollen, and there is a whitish granuloma in the choroid involving the whole eye. And there is a retina is also detached, sensory retinal detachment. This is a tricycle eye, and you can see that angiogram showing the whitish lesions over here. There is a, nowadays we have equipped with a real imaging facility, and I published this article, multimodal imaging in sympathetic ophthalmia, fundus autofluorescence, fundus fluorescent angiogram, optical coherence tomography, indocyanine green angiography, USGB scan. So what we see in the fundus autofluorescence, I don't want to go into the details of that. You see the initial stage, whitish lesion, that's a hyper-autofluorescence, and late stage black area, hypo-autofluorescence. And then fluorescent angiogram, if you do it, you will see that pinpointly, like starry skies pattern, and there is a pooling of the dye, like the pockets of the fluid of the fluorescent dye. And you can make a precise diagnosis by these features. Not only that, we can do optical coherence tomography, is a kind of a new imaging tool where the retina, this is the retina, is detached from the choroid, and retina is detached from the choroid, and there is a multiple pockets of the fluid is seen in this picture. It's not moving. And there is a nodules in the form in the choroid called Dallen-Fuchs nodule. It starts from the choroid and behind the retina. And you can see the similar picture in histopathology. These are whitish nodules over there, and underneath the retinal pigment epithelium, this is the choroid, and you can see the collection of lymphocytes and epithelioid cells. So how do you treat it? We give it a very high dose. This is a 1 week patient, and that has got autoimmune uveitis. We give IV with prednisolone 1 gram daily for 3 days, followed by the high dose of oral steroid and the immunosuppressive agents like azathioprine or mycophenolate mofetil. And if not responding, do triple agent immunosuppressive agent cyclosporine. So next entity, we will go to that little bit about the VOC coronary heart disease. Why I talking about this disease? This mimics sympathetic ophthalmia. It's also an autoimmune disease. This is a 34-year-old man who had like a headache, and he lost vision 3/60 in the right eye and 2/60 in the left eye. Had got history of fever-like thing. And this patient, if you look at the eye, there is a retina has got multiple serous retinal detachment, pockets of fluids. Disc is hyperemic. And you can see that again a starry skies pattern and collection of fluid in the posterior pole. And this is in the left eye, same thing. And Sweps's OCT showed multiple pockets of serous retinal detachment with septi. And then ultrasound, if you see, there's a choroid is thickened, and this is a diffuse posterior choroid thickening is seen. How to treat it? Again, we give intravenous methylprednisolone, and this followed by the oral prednisolone 1 milligram per kilogram of the body weight, add immunosuppressive agent. This patient got back vision to 6/24 and 6, and this is a post-treatment complete resolution of inflammation. You can see no more pockets of fluids in the retina. So this is the treatment, and Patient last reviewed on the 6.9, 6.6 is normal, 6.9 and 6.75 in the left eye, and was continued from tablet prednisone 10 milligram and tablet azathioprine 50 milligram 2 times daily for 2 months and for once daily for 6 months. Treatment is typically 9 months to 12 months. It's an autoimmune disease. Even if you show complete resolution of inflammation, you need to continue the immunosuppressive and steroids for a long time. And this is the 3 diseases Alfred Vogt, Dr. Koinange and Dr. Harada described this disease. And I showed you that it comes with a headache and CNS symptoms like vertigo, auditory tinnitus, etc., meningitis headache. And the patient doesn't come to the ophthalmologist. Patient go to the neurologist. And neurologist sees the disc edema in the direct ophthalmoscope and thought that this is a neurologic disease. And by the time is that one is often too late. And this patient can also develop cutaneous manifestation like vitiligo, poliosis, and alopecia, but it occurs in the late stage of the disease. How common is the VKE? This is the largest series published by me in the Japanese Journal of Ophthalmology. I took a challenge to publish in Japanese Journal where this type of disease is seen, and then it was got published, and 2.2% of all uveitis cases has got VKE, and 92% of all pan-uveitis. We found that imethyl prednisolone, high-dose oral steroid, immunosuppressive agent has been found to be useful. You don't need biologic agents usually. In recalcitrant cases can occur. It is a very dangerous disease. If we don't treat it properly, it can be blind eye because due to the cataract, glaucoma, seen choroidal neovascular membrane, subretinal fibrosis, cystoid macular edema. So we need to hit hard with the steroids and immunosuppressive agents at the beginning of the disease. Third disease I like to talk about is a little bit more detail about systemic lupus erythematosus. It's indeed a real challenge to ophthalmologists to treat this condition. And let me start with the case. This is a 16-year-old girl from Bangalore, history of joint pain, ESR raised, blooding of vision in both eyes. When I looked into the eye, right eye has already got vitreous hemorrhage and fractional retinal detachment. And the left eye has cortical spots and retinal vasculitis. And we had that time anti-double stranded DNA only, and that was a positive. We treated when this patient had malar rash and then retinal vasculitis. So SLE is a chronic autoimmune complex constitutive disease, as you know, with a relapsing and remitting clinical course. But most important thing to remember, 1/3, 33% of the SLE patients can have ocular involvement. Many of them can have the posterior segment involvement. So it can be the initial presentation of the disease, can affect any part of the eye, but if it is affect some part of the eye, that's not a problem. Worsening of the ocular disease indicates systemic disease activity. So if we see the eye is involved, we need to take these patients much more seriously and be aggressive. I don't want to talk about the pathogenesis of vasculitis to this audience, and they know. So it can be episcleritis, like inflammation of the front part of the eye, which is innocuous and can be treated with topical steroids and systemic steroids. But when it involves the back part of the eye, lupus retinopathy, retinal involvement is seen in 2 to 33% cases, potentially blinding ocular disease, decreasing with much better management, and systemic disease today tends to be bilateral, maybe asymmetrical. So lupus retinopathy, 2 ways it's present, directly by immune complex mediated disease, and it can produce secondary hypertension and produces hypertensive retinal changes. So microangiopathy, vasculitis, severe vaso-occlusions, these are the 3 types of the direct retinal damage. So there can be mild, moderate, and severe. Mild is a cortical spots, dot hemorrhage, microaneurysms, hard exudates, good prognosis. But when you become moderate, we get retinal vasculitis, cortical spots, retinal vein vasculitis is then vaso-occlusion is the common endpoint of the vasculitis, and it can have vaso-occlusive retinopathy in severe lupus retinopathy, which comprises of central retinal artery occlusion, branch retinal artery occlusion, central retinal vein occlusion, branch retinal vein occlusion. Can develop neovascularization, vitreous hemorrhage, retinal traction, retinal detachment, and rarely, very rarely, pseudoretinitis pigmentosa, pigmentary changes in the retina. I'm showing in that one patient. If you see the fundus, there's a lot of hemorrhages over there. This is so dramatic that we put this photograph in the cover page of the Retina Atlas, which we have published. And there can be retinal branch retinal artery occlusion. There can be central retinal artery occlusion leading to the complete loss of vision, and there can be vitreous hemorrhage. So I just wanted to show you a 18-year-old girl which I've seen recently, which has got only light perception. And this patient has SLE, Barth-Chiari syndrome, and Apra syndrome 1 year. And this patient had undergone all the kinds of investigations and was on tablet, had received anticoagulant, IVMP, omnacortil, warfarin tablet, Slexan injection, and Celsep tablet, microfilm Mofetil. And you had also have glaucoma. I wanted to show you how devastating hemorrhages can be there with the retinal hemorrhages involving the whole right eye. And there was only light perception was present. And left eye was fortunately normal. We treated the patients with tablet azathioprine 50 milligram PDS and tablet prednisone 60 milligram per day. We took rheumatologist's opinion to whether to start on rituximab. He said that you can see the anticoagulant, and this is the resolving hemorrhages. And these patients in day before yesterday, 13/7/23 vision was hand movement, lesions as resolving. So lupus retinopathy, indirect retinal damage can occur, arterial attenuation, AV crossing changes, cotton spots, disc edema due to the secondary hypertension. So we published retinal involvement in systemic lupus erythematosus. Vitreous hemorrhage, bleeding inside the eye, was a common manifestation and was in 38.89%, followed by retinal vessel inflammation. So SLE retinopathy and risk for the life, survival decreases as well as whenever we see the SLE retinopathy. So if the patient has got ocular involvement, then it indicates that we need to be aggressive. Both ophthalmologists and rheumatologists should be aggressive in management of this patient and would work hand in hand. One can have choroidopathy also. This is much less dangerous. And there is not the retina is involved, choroid is involved. We have seen recently one case. We do fundus fluorescent angiogram to find out the capillary non-perfusion and do laser photocoagulations in this case. And here is a patient with acute severe vision loss in both eyes with fundus fluorescent angiogram showing capillary non-perfusion. One can have choroidal infarction, as is seen in this case with uveitis. And this is a multiple cotton spots due to the SLE, and you can see the optical coherence tomography, and which showed such thickening of the retina with nerve fiber layer. So how do you manage? Initial treatment with the oral corticosteroids may be preceded by IVMP. And nowadays we are more and more aggressive and treat such patients with immunosuppressive agents in conjunction with the rheumatologist. Significant vaso-occlusive disease when the patient is having antiphospholipid antibody and treated with anticoagulants and low-dose acetylsalicylic acid. Proliferative retinopathy is treated with a laser photocoagulation. We are very aggressive in this treatment. One of the important things is that not only the disease itself, the treatment itself can produce problem. If you can give, as the patient because prolonged steroid treatment, they can develop cataract, glaucoma, and a condition called central serous retinopathy with the steroid-induced complications of the retinal fluid collection, sensory neuroretinal detachment. And we rheumatologists often love to put the patient on HCQ. If the patient is put on the long-term high dose of HCQ, they can have bullseye maculopathy. That's called chloroquine retinopathy or bullseye maculopathy. What we need to do is the baseline fundus examination, as well as the Humphrey visual field, electroretinogram, and optical coherence tomography. So rituximab can also be used in the SLE retinopathy in the reverse. So this is a 32-year-old female. I don't want to go into the details of this patient. I just want to show this picture, and you can see the retina is detached, and there was a multiple corneal spots with hemorrhages there, and this patient was treated with immunosteroid. Vision did not improve much and had persistent inflammation, and the patient was given rituximab, and this patient showed significant resolution. You can see the retina is attached, foveal contour is maintained. So next stage coming to that, one is the Behçet's disease, is another autoimmune disease, and here is the chronic relapsing vaso-occlusive disease, unknown etiology, and panuveitis. What is the problem is that by the time we see they diagnose this patient, if it's not referred to in time, they can develop optic atrophy. So these patients have cold mobile white hypopyon. Patient is not aware of it. They can have severe vasculitis, arthritis, and phlebitis, and can have optic neuropathy and cystitis. So genital ulcer, oral aphthous ulcer, dermographism, erythronodosa. Most important thing is the painful oral recurrent aphthous ulceration. And we have got a tool called angiography, fluorescent angiogram. If you do the fluorescent angiogram, you can see the capillary farming in such cases, which is quite characteristic of Behçet's disease, but can be seen in intermediate uveitis also, but is very characteristic. It indicates severe inflammation of the vessels. What we need to diagnose in Behçet's disease, that the patient, of course, will need oral aphthous ulcer, and then can have anterior, intermediate, anterior posterior uveitis or retinal vasculitis, and they can have phlebitis, thrombosis, etc. And capillary farming is quite characteristic, and fundus fluorescent angiogram as shown in this case. We can do the pathology test and HLA-B51, which is not a diagnostic test. Patient can have HLA-B51 positive, no Behçet's disease, or HLA-B51 negative and have Behçet's disease also. How to treat it? I no longer use corticosteroid alone. I put the patient straight on cyclosporine, straight on immunosuppressive agent, azathioprine or cyclosporine, and biologics. We have started using biologics in Behçet's disease. I'll be showing you. This is a patient which have treated with a cyclosporine pre-biologic era, and you can see that 1 week and 6 weeks, 4 weeks after, there's a complete resolution of involvement. If you don't treat aggressively, what happens is that they can develop optic atrophy. Biologic, this patient was treated with infliximab and has shown good response. Recently, in the May 2023, we have published 25 cases of Behçet's disease, largest series from India by an ophthalmology center, and we found that it is bilateral in majority of the cases, and majority of the patients require steroid and immunosuppressive agents or steroid immunosuppressive and biologic agents. And that showed good resolution. Our experience with biologics has shown that this is a disease which should be treated with immunosuppressive and or biologic agents. Next, coming to the juvenile idiopathic arthritis uveitis, is a chronic disease. Unfortunately, it can cause also blindness. The patient is not aware of this disease. It's the most common childhood autoimmune disease, most prevalent systemic disorder in the children with uveitis, arthritis of at least 6 weeks duration without any identifiable cause in children younger than 16 years. So risk factor pauci-articular type. This is a common which has got eye involvement, and I will tell you the few minutes after that how should you rheumatologists and ophthalmologists should see such patients. Knee joints commonly involved, ANA positivity, female, onset at less than 4 years of age. Why it's important? They can have blinding uveitis. They can have chronic anti-uveitis which remain silent, and the child often don't tell. They can develop band-shaped keratopathy as seen in this picture, in the one whitish material deposited on the cornea. They can have cystoid macular edema, hypotony, pressure goes down due to the chronic inflammation of the ciliary body. And the children often don't complain of the eye problem. And by the time we see it, and there is already a pupil is irregular and there is a complicated cataract. How do you treat it? First treatment is a topical steroid with or without short-acting mydriatic agent. But 97% of the uveitis specialists feel that we need to do the immunosuppressive agent, particularly in methotrexate. And the treatment with the systemic immunosuppressive medication decrease the risk of visual loss in GIA. All my patients of GIA with uveitis is all either on methotrexate or methotrexate with TNF alpha inhibitor. And 73% of the pediatric uveitis specialists says this is one of the indications of the TNF alpha inhibitor. And in recent past, which you are feeling that I'm finding that many of this disease is doing well, very well with adalimumab therapy. And then they require complications for the surgery, like complicated cataract, lensectomy, vitrectomy, phacoemulsification, IOL, EDTA chelations for the band-shaped keratopathy, for the glaucoma surgery. So this is a article published in New England Journal of Ophthalmology, New England Journal of Medicine, adalimumab plus methotrexate for uveitis in juvenile idiopathic arthritis. In fact, Dr. Ramanan from Bristol has studied that what is called classic study of sycamore study, where there are 90% multicenter double-blind study, randomized placebo-controlled trial, and this patient showed that the patient who are put on the adalimumab with methotrexate doesn't have much recurrence and do very well. So this is a band-shaped keratopathy, and I just want to show this picture. So how horrible is the eye cornea, and then that becomes clear with EDTA chelation, and you can have good vision. And this is a story of a girl. He has got 25 years history of GI. When he came at 5 years to Sankenetralaya, he had got juvenile idiopathic arthritis associated with uveitis. We treated with methotrexate, did not really require, developed a hypotony and in the right eye vision 1/60. We did lensectomy, vitrectomy, and still there's a chronic inflammation. Left eye, we could preserve the vision, 6/9 band-shaped keratopathy, which we did the EDTA chelation. And then patient was put on infliximab injection, referred to the rheumatologist, and then was put on topical steroids and prednisone. When you look in the retina, there is a lot of choroidal infiltrate is seen over here. And this patient did not tolerate infliximab, put on adalimumab, did not respond, and developed a huge cystoid macular edema. Retina is elevated over here. Then we consulted Ramanan, Professor Ramanan, who said, why don't you try injection tocilizumab? And with the injection tocilizumab, the patient's vision improved, and there is a cystoid macular edema, which has elevated retina, has become normal. So phacoemulsification with intraocular lens implantation is different ballgame, and you can treat such patients with cataract extraction. Lensectomy, vitrectomy is much better because they do have a chronic inflammation, can lead to the hypotony. So intraocular lens implantation is not a good idea in majority of the cases. But with the usage of biologic agents, we are much better positions now. Algorithm of treatment of this is the most important slide. And if we diagnose anterior uveitis and the local steroid in this, ophthalmologists should see such patients every 3 months. And then the patient should be treated with methotrexate, and if not responding, biologic agents, and every 3 months till the patient is 5 years of age, then every 6 to 12 months. They need a chronic long-term follow-up. One of my patients who is doing the medicine, a GIA patient, although the one eye is lost, So these patients, if a wrong follow-up is there, immunosuppressive and steroids, they can have a successful life. And next is that coming to HLA-B27 syndrome is easier to treat. HLA-B27 gene on chromosome 6, and HLA-B27 is a major histocompatibility complex cell surface on the it has got the sometimes now it's thought to be microbial antigens to the T cells. Almost all nucleated cells in the body at class 1 HLA month. What they have, they come with a kind of a uveitis. Looking at itself, we would be able to diagnose it because they contain a lot of fibrin material and hypopian. HLB most common identifiable cause of anterior uveitis and is seen in the Western countries more well, but you have started seeing in India also. Spectrum of HLA-B27, ophthalmologist sees as acute non-granulomatous anterior uveitis, and rheumatologist sees as ankylosing spondylitis, psoriatic arthritis, inflammatory bowel disease, reactive arthritis, undifferentiated spondyloarthropathy. Systemic association of HLA-B27 associated anterior uveitis, they can have the collagen disease, and key points is that they are young male, 20 to 40 years, 2 times males are more affected than the female. So recurrent unilateral or alternating, we call it ping pong ball. Acute pattern triad of pain, redness, and photophobia. Patient says that I cannot look at the light, the room light. And this is the main symptoms of this patient. High fibrin content, hypopian 12 to 15% cases. They are typically recurrent, characterized by the full remissions between the attacks. Possible triggers include infections with gram-negative bacteria, stress, specific ovulation. People after menstruation can get before exam they can get recurrence of uveitis. Frequency of attack decreases with the age of the patient, so it's not a lifelong disease. Subjective symptoms often report an early stage. Is very important thing is the patient himself can tell that he is getting an attack. Eye is becoming heavy. I often ask the patient to do the self-medication, to start the patient on topical steroids, keep it in the refrigerator in the non-freezing area, and start putting the drops only 1 hourly. And that way we can save the vision. Don't ignore the premonitory symptoms. They can have posterior segment involvement, 75% vitritis, in 2 series, around 70% vitritis, and posterior segment manifestations. They should be distinguished from endogenous endophthalmitis. So they might require that an infective uveitis, but when you can see the retina, when there's a history of recurrence, you always think of HLA-B27 positive anterior. They can develop cystoid macular edema, which is shown in the fluorescent angiogram. They can develop complicated cataract, fibrin content. Why should we investigate and refer HLA-B27 positive? We ophthalmologists treat them, if they become old, or they become all right, but we need to refer. We are really is bound to refer, should be responsible for referring this patient, because 66% of the HLA-B27 positive anterior uveitis develop spondyloarthritis within the 9-year period in comparison to the 6% HLA-B27 negative. So they often harbor a latent collagen disease. If HLA-B27 positive, it is necessary to exclude other causes of uveitis. Yes, of course, HLA-B27 is not the synonym for a type of uveitis. Can be positive in other uveitic condition. Simple HLA-B27 should not rule out other diseases. It should be having non-granulomatous uveitis. If a granulomatous uveitis is associated with HLA-B27, you should rule out TB, sarcoid, etc. Always correlate clinically. How do you manage? Easy, topical steroids frequently, every 1 hour. I even given every 15 minutes. Cycloplegic agents, mediatic cycloplegic agents, and management of HLA-B27 systemic therapy, sulfasalazine, methotrexate, and biologics. We are the first people to report a series of biologic agents in the recurrent HLA-B27 positive anterior uveitis. Many of them has got ankylosing spondylitis, and they had got a uveitis-free life after using of anti-tumor necrosis factor alpha agent, particularly adalimumab. Mission is the prevention of vision. We have used oral methotrexate, and this oral methotrexate can reduce the rate of recurrence. The drug is safe and effective. Patient having 9-10 times recurrence per year, we put on the methotrexate 15 milligram per week, reduction of the recurrence has reduced. So methotrexate is an option for preventing the recurrence of acute anterior uveitis. So clinical characteristics, I've told it, I don't want to repeat it again. It's recurrent uveitis. Now I'll go to that. Another one is the ankylosing spondylitis. This is seen by the rheumatologist mostly, and they come with a chronic sacroiliitis. Up to 90% patients of the HLA-B ankylosing spondylitis, HLA-B27 positive, and they have the bamboo spine. What they have, a very characteristic uveitis, fibrin and hypopyon. And this is often on the 40% patient of acute anterior uveitis of undiagnosed spondyloarthropathy. Now coming to the Bloss syndrome, which is a rare, and this is a patient which has seen arthritis involving the interphalangeal joints, maculopapular dermal rash, and this has got a Bushaka's nodules, and after treatment with the adalimumab, the patient became all right, and we have reported in the Indian Journal of Ophthalmology the first case of the Bloss syndrome from ophthalmologists. So next is that King syndrome, tubular interstitial nephritis. We see this is the patient has got interstitial nephritis, and the patient has non-granulomatous anterior uveitis. We treated with the topical steroids, oral mycophenolate, and prednisolone, and patient become all right. And this is the first report from India by us. Psoriasis can also have anterior uveitis, and their treatment is not different. We can treat with the immunosuppressive agents and steroids or steroids alone. Coming to the scleritis, is a few more slides. Most common type of scleritis is the diffuse anterior scleritis. They are usually non-infectious. About 90% of them are non-infectious. They can have nodular scleritis, necrotizing scleritis, which has a common association of systemic collagen disease, rheumatoid arthritis, and granulomatosis with polyangiitis, which are earlier known as Wegener's granulomatosis. So rheumatoid arthritis, granulomatosis, polyangiitis, relapsing polychondritis, polyarthritis nodosa, systemic lupus erythematosus. Rheumatoid arthritis, they call scleritis only, scleritis or sclerosis, responds well to the corticosteroids or immunosuppressive agents. Nowadays, I use the immunosuppressive agents. Methotrexate is my first choice. And you can see the same picture. The patient has scleritis with rheumatoid arthritis. I just end with a challenging case, and this is a patient of necrotizing scleritis, and the patient has got such a scleral necrosis. The retina is pulled inside, and due to that necrosed uveal tissue and sclera, the patient had cavitation in the lung, and the pulmonologist thought that it is a tuberculosis and treated with the anti-tubercular medication. But when the patient was admitted over here, I put the intravenous methylprednisolone. The next day, the patient was not able to get up. And then there's got palpable purpura on the hand and feet, blood urea 47, serum creatinine, 4 milligram, and the patient has rapid retinitis progressing towards the posterior pole. The patient was admitted, and renal biopsy showed concentric glomerulonephritis, complete weakness, granulomatosis, CNCA was positive, and there's a sterile hemorrhagic one. We treated with IV pulse cyclophosphamide, followed by the oral cyclophosphamide and advised scleral graft. And ultimately, we could preserve the vision. And this is the patient. Patient stayed as the one. He gifted me one kurta, but the patient ultimately 2 years after, he died of the systemic complication. These are granulomatosis with polyangiitis, Most common cause of vasculitis associated scleritis, more severe presentation, more aggressive course, can be localized form of JPA, needs immunosuppressive agents. We ophthalmologists should do investigate all cases of scleritis to rule out collagen disease. I tell my postgraduates it's a crime not to investigate a case of non-infectious scleritis. So we published an article in a multi-center study. Eye is a common site of granulomatosis with polyangiitis, a collaborative study. Scleritis therapy is easy. NSAID is the initial presentation of indomethacin, systemic steroid. But if the patient has necrotizing scleritis, we see immunosuppressive agents by either cyclophosphamide, methotrexate, azathioprine, or mycophenolate mofetil. Rituximab can be used for the refractory scleritis. Nowadays, we have used another agent called tofacitinib, JAK inhibitor, and we have published one case of JAK inhibitor in the tofacitinib in scleritis. So I think I've taken quite a lot of time, and I finish it here. So 50% of the uveitis are non-infectious or autoimmune. 90% of the scleritis are non-infectious or autoimmune. Immunological tests are often necessary. Investigate in such cases, particularly scleritis, as I mentioned, is a crime not to investigate. Multidisciplinary evaluation in the management, rheumatologists, dermatologists, nephrologists, etc., is often required. I feel it's absolutely necessary in an SLE case to take the help of rheumatologists. A case of JIA, take the help of pediatric rheumatologists. Immunomodulation with corticosteroids are often necessary. And biologics have emerged as a new weapon in the armamentarium, though we have got limitation regarding the cost and continuation of the therapy. With this, I like to express my sincere gratitude, giving me the opportunity to share my thoughts and experience on autoimmune uveitis. I like to talk on this topic because every day I see autoimmune uveitis and scleritis. Every day I talk to a rheumatology friend. I'm shameless in calling them and telling them my story first, and then telling what we should do together. Thank you very much.
Thank you, sir. We are really honored to have such a wonderful talk by you today. Will you take a few questions, sir?
Sure.
Yeah. So two questions are on latent tuberculosis. So a patient with uveitis and just a TB gold or a Mantoux positive, but no other evidence of active tuberculosis. What is your experience with treatment in these patients?
So we do look at the phenotype of the uveitis. If it's a granulomatous uveitis, multi-cut gapes, Kopi nodule, Bruchac's nodules, and have got that Mantoux quantiferon TB gold test positive, we start the patients on antitubercular therapy. But in our center, we have got facility to do the PCR, polymerase chain reaction for Mycobacterium tuberculosis. So we take a fluid from the eye, which is a very innocuous procedure, very safe procedure, and do PCR, nested PCR for MPB64 and IS6110 region, and rule out intraocular fluid, which has got good sensitivity and specificity. Because once you start the patient anti-TB treatment, you have to give a treatment for 9 months. And this drug can also cause hepatotoxicity. Simple Mantoux and quantiferon TB gold test positivity, I don't treat the patient with anti-TB treatment. A patient giving recurrent anti-non-granulomatous anterior uveitis, I do only one test, HLA-B27. I don't do Mantoux and quantiferon TB gold test at all.
You talked about cyclosporin. Is it oral or even topical cyclosporin you use?
The topical cyclosporin works in the dry eye, but oral cyclosporin is the drug of choice. Topical cyclosporin has got no role in uveitis.
Out of azathioprine and mycophenolate mofetil for autoimmune eye diseases, which would be better in your experience?
I use routinely mycophenolate mofetil because azathioprine, that the TPMT test, that is a bone marrow suppression, which is not available. Bone marrow suppression is a problem with azathioprine more than the mycophenolate mofetil. And that's what I use mitochondrial mofetil, and there are chances of having that this hepatotoxicity is little less.
So after how long do you feel they need to biologics they will need? Like how long do you wait each time before escalating the immunosuppression?
So I wait for a 6 weeks to 1 month period to work, and even methotrexate I wait for 3 months to see that it is acting or not. So in GI or this ankylosing spondylitis associated uveitis, I often use methotrexate as a first line of children. In children, my methotrexate is my first line of treatment.
Okay. Patient of lupus has central serous retinopathy and now needs steroids for lupus activity. How do we approach?
That's a very important question. It's really a problem. Central serous retinopathy can produced by the steroids, and here I try to treat with the biologics or immunosuppressive agents and avoid steroids, because the patient can lose complete loss of vision by central serous retinopathy, particularly when it's a multifocal type. The retina can get detached, and when they resolve, they develop with a lot of subretinal fibrosis. So having a lupus is less dangerous than having a central serous retinopathy.
Tofacitinib, and how many patients have you used, sir, with eye diseases?
I have used it quite a lot now. I have now series in tofacitinib that has been published in Ocular Immunology and Inflammation. I might have, me and my colleague might have seen 50. We have got 3 publications on tofacitinib. We have one patient of tofacitinib developed herpetic keratitis, and one patient developed branch retinal vein occlusion. Otherwise, I didn't have any complications. The cost is less, and they are very much acceptable by the patient. So tofacitinib works quite well until unless it's a severe vasculitis or severe collagen disease. So diffuse non-granular, diffuse anterior scleritis, tofacitinib is often our choice.
Should we send our GIA patients to screen for CAU to the ophthalmologist on the first consult itself, or are there any specific time or signs that we should look for?
I think is that all GIA patients should be sent to ophthalmologists, because they are so silent uveitis occurs and they develop complicated cataract and glaucoma and band-shaped keratopathy. I feel I tell my rheumatologist to send all GIA patients to uveitic clinic.
And how frequently should we tell for follow-up? How frequently should they follow up with you?
Yeah, see, if they have got, once they have ocular involvement, they should be seen every 3 months. If it is not done, every 6 months of a non-ocular involvement.
Many of the lupus patients develop early cataracts, as you said. So when you take up for cataract surgery, what is your recommendation? Should we continue all the ongoing immunosuppression?
Yes. They do the one, and if the patient on 10 milligram oral steroid, I hike up to 40 milligram.
Okay. Dr. Danda, sir?
The cataract involves touching the iris tissue. So touching the iris tissue that produces an additional inflammation. So you need to protect the patients with steroid 3 days prior to the treatment.
So for the eye, we need to hike up the steroids for how long, sir?
Yeah. So 40 milligram per day for a week. And if there is no exacerbation of inflammation, you taper quickly. And if there is exacerbation of inflammation, you taper according to the inflammation. So routinely, my all patients who are undergoing cataract surgery with scleritis or with GIA, they are hiked up oral steroid 3 days prior to surgery.
Dr. Danda, sir, would like to ask or comment?
Nothing. I just say that this is a very comprehensive and very detailed presentation of the eye manifestations in autoimmune diseases. And I think there is nothing more to be added from my side. Thank you very much.
Thank you so much, Dr. Biswas, Dr. Danda, to be here today. We are really honored to have this session today. Thank you everyone for being here on this Sunday morning. And I wish you a happy evening. Goodbye, all of you.
Thank you.
Sir.
Thank you.
Thank you.
It's a great privilege. Dada, দেখা হবে আপনাদের সঙ্গে।
Thank you. Thank you. Thank you. Thank you, Dr. Kavita.
Yeah.
Thank you.
Thank you, Dada.
Bye-bye, sir. Good day to
Bye.
all of you.
Bye. Same to you.
Yeah. Thank you. Yeah.
Bye. Bye.